to, I think this is the 4th public board meeting of Manx Care. And as I said later on, hopefully the last before we've got these social distancing requirements, and we can just have it as open as possible, but we'll have to wait and see. In terms of apologies, I have apologies from Oliver Radford, Director of Operations, and it records in the agenda the resignation of Vanessa Walker, but what I'd really like to do is just to take this opportunity to pay a tribute to Vanessa Walker, who hasn't just resigned. Sadly, a week or so ago she died, having known for a year that she had a serious cancer and struggled on during that year, coming here and committing herself to Manx Care. And you can see in my chairman's report that I've talked about the extraordinary skills and experience and learning that she brought to the board, but also the extraordinary personality that she brought. She was both very challenging, very supportive, and very funny from time to time, but a really sort of hugely warm human being that I know we all miss. And in a couple of moments I want us to have a minute's silence for her. And I want to also acknowledge that a couple of other employees of Manx Care also died recently of cancer. I'm not going to name them in public because we haven't got approval to do that, but it is worth acknowledging. So I just invite anybody that wants to say a few words about Vanessa to do so now. Perhaps Sarah, you could go first.
Sure. I was running along the prom and trying to think what to say. I think I only met Vanessa just a little under 18 months ago, and my life is much richer for those 18 months. I think her compassion and her passion are the things that I will remember. I think her commitment to quality, to patience, and to those that work for Manx Care, wanting to hear people's voices, really, Chair. I think that's the thing that I will remember and will endeavour to ensure is her legacy, that we continue to listen and to hear what people are saying and to make that front and centre of our decision making, because ultimately every decision that we make as a board will impact on those people that work with us and those people that receive care from us, and I will miss her enormously.
Thanks, Sarah. Katie?
Yes, I also met Vanessa at the same time, and Sarah's words really resonated with me. My choice of colour today is pointed because Vanessa was vibrant, she loved colour, she loved a party, she threw herself into absolutely everything she did. So this is in tribute to Vanessa, and I'll miss her greatly as well.
Thank you. Anybody else?
I'd like to join in, Andrew, if I may, please. And I think, look, there's no easy way to lose a friend and a treasured colleague in any organisation. And I think that Vanessa had an impact on us all, and this organisation is not in doubt. I feel also that the way in which she contributed, that funny blend of experience and intelligence, overlain with a good dose of Manx Yorkshire common sense, will be very sadly missed. And as we pause to bid her farewell, I think, as you say, it is also very important to remember others who have lost their lives whilst in this service. Vanessa would have been the first to do this, and I think it marks the tone of our operation as we go forward. She epitomised what I think we want to be, a caring, effective organisation, and our world will be a duller place without her. Thank you.
Very good, very good. Yes, Andy, did you want to say anything?
Actually, no, if you don't mind, I think everything's been said that needs to be said.
That's fine, okay, we'll just...
black tie is quite deliberate.
Oh, different choice of colour, yes, right. Okay, so Teresa, to finish off then.
Yeah, no, thank you, Chair. And I guess I'd had the pleasure of working with Vanessa since 2015. We'd both been on the board of two organisations in Hull. The first one, a mental health and community organisation, and the second, the Acute Trust. Vanessa had such breadth of experience and such a sense of partnership that in whatever role she did, she managed to join agencies together, and absolutely resonating what Sarah and Katie have said, she always ensured the patient and service user voice was heard, and that was at the forefront of our minds as boards when we were making decisions. So when I was appointed into this role here, I didn't know Vanessa had the connections to the island that she did. But over those months between me being appointed and actually arriving on the island to do the job, I met Vanessa several times, and actually she became a friend more than just a colleague. And she told me that I was right for this job, and that this job was right for me, and that was a huge endorsement and a huge confidence boost as I made this massive sort of personal journey and professional journey to be the chief exec here of Manx Care. So I feel greatly privileged that I had the opportunity to work with Vanessa on 3 separate occasions, and all the work that she did for Manx Care in the time she was with us will live on, because she's instilled such a huge sense of purpose and clarity of objectives and passion for what we do and how we do it here on the island and in Manx Care, that her work will continue.
Thanks, Teresa. And I would appreciate it if we could just all stand for 1 minute silence for her. Right, back to the agenda. So we have the usual declarations of interest which have been circulated with the papers. Does anybody... sorry, I beg your pardon. I should introduce 2 people first of all. So first of all, Andy Chittenden, who's our new interim board secretary. So welcome, Andy. Look forward to working with you in the coming months. And secondly, to Dr. Oliver Ellis, who is our new medical director of primary care, who joins us today and is going to work with us on the various initiatives that are taking place in primary care and give leadership to that. So you're very welcome, Oliver. So, as I was nearly there, because it reminded me, the declarations of interest are with the papers. Dr. Ellis has actually sent me his, and they will feature in the next publication. Does anybody wish to add or subtract anything from those declarations of interest? Okay, thank you. Then I've got the minutes of the meeting on the 23rd November, the last public meeting. Again, I'm asking for any comments on the accuracy of these. Does anybody have any problems with that? Good. And then we have an action log, which has only got the 1 item on it, which is actually on the agenda for today anyway. Does anybody think there should be any other matters arising which we've missed out? No? Okay, that's good. Next, when we come to any other business, does anybody want to say anything now and to notify us of anything that will come up then? No? Okay, fine. So now we do reach the Corporate Risk Register and Board Assurance Framework, the written update, and we're going to look in more depth at Risk 1 through Paul. It says Board Secretary too. Do you want to say anything, Andy, at all to start with, or we just...
Perhaps chip in with comments later on.
Fine. Okay, so over to you, Paul.
Thank you, Chairman. I would ordinarily at this stage invite the board to take the paper as read, but if your paper is anything like mine, the text is incredibly small. So if you would allow me just to explain what's in there, and then I'll talk through how we've organised this risk. So this is a risk that might happen, not necessarily is happening. So it's trying to stand in the future. And essentially, the risk is that Manx Care may not be able to provide safe, high-quality care to meet the needs of service users. And that this might arise as a consequence of insufficient safety management or culture, ineffective clinical governance arrangements, a lack of suitably qualified or skilled staff to perform duties, inadequate business intelligence and oversight of quality of care. And if that were to happen, it may result in an unacceptable exposure to avoidable harms for service users, unsatisfactory patient experience, an inability to deliver outcomes of care in accordance with the requirements imposed on Manx Care, which may in turn lead to intervention by the Department of Health or regulators and adverse publicity. If you look at the table, the way it's laid out, it then takes us to consider what the control framework is that we have in operation for mitigating that risk. And if I just talk you through some of those, I said to go through all of them. But essentially, when it comes to staffing, the control framework for staffing will involve having clear budgeted establishments in place so that we can be confident we have the right numbers of people with the right skills and the right level, that we are proactively managing rotas, so at least 6 weeks in advance, which gives us the best opportunity for planning ahead and filling gaps in a managed way. That annual and study leave is applied for properly and it's approved in accordance with the policy so that we don't have a situation where too many people are off at the same time, for example. Mandatory training is there to support colleagues to be able to fulfil their duties to their best ability, and also to mitigate some of the key clinical risks that are inherent in our service. From an operational point of view, we'll be checking the bed states and the staffing requirements so that we're satisfied we're safe to start and run the operation of healthcare in a way that is acceptable to everybody. And if it isn't, that we get into a huddle and consider how we adapt to make sure that we prioritise accordingly. I've used the phrase judicious use of bank and agency staff because I think it must be. We need to make sure that because they're expensive resource if we use them, but from time to time we will dip into what I would call contingencies to help us if we find ourselves in trouble. So whilst we might plan our rotas and have establishments, it doesn't necessarily mitigate against the risk of unplanned sickness, for example, in which case we need to cover with some external help. And in some cases, we will redeploy colleagues if we find that in one particular area we're very short, in another area we are reasonably well staffed. We will redeploy colleagues internally to help balance the risks. In terms of clinical governance, the control framework will involve the mechanism that we have in place for overseeing quality of care. So we have developed at Manx Care a quality dashboard to help us with that. And it will include a range of what we call leading and lagging indicators. So a lagging indicator is something that will look back. A leading indicator is something that will give you insight into what's coming. We have an integrated performance report, which you will see in your board pack today, which helps give emphasis to a range of measures. It's integrated insofar as finance, performance and quality are inextricably linked, and we're able to oversee that. We will rely on a broad range of policies and procedures to help govern how operational and clinical decisions are made and how we work as practitioners. To help us understand if there are problems or what we call defects, we have an incident reporting system in operation right across Manx Care, and it's supported with serious incident procedures in the event of a significant issue arising. And in addition to that, we have oversight mechanisms through the complaints handling process too, where we can take stock of any concerns that are raised from service users. And more recently, we've established something called an MCALS, which is an advisory service to help signpost people who have got particular issues on the day. And the idea behind MCALS, which I think is quite a good success for us, is that we can resolve the problem on the spot where that's possible and signpost people to a resolution really quickly. And I think that's got to be the goal rather than people struggling. We have oversight of all of that in the operational clinical governance groups, for which there is one in social care and one in acute care, which is subsequently overseen and assured on the board's behalf by the Quality and Safety and Experience Committee. And underneath, we have various groups managing some of those things. So that's the control framework, as imagined. We also itemise where the assurances would come from. I don't propose to go through those, but they're for reference. Those assurances will evolve and mature as we go forward across Manx Care. But we use the opportunity in the board assurance framework to highlight what we call gaps in control. And I would say at this stage, it is a sign of strength, in my opinion, for a board to have awareness of its gaps in control and gaps in assurance, and to be able to discuss and agree how it goes forward. So whilst reading some of this might be difficult for some people, it's actually a very important step in going forward. So I've itemised here some of the areas which I would consider to be gaps in control, but I would caveat what I've said in the paper with the fact that Manx Care is within its first year and is evolving and learning how to build a resilient healthcare operation. And therefore, I would not expect these things to be absolutely nailed down at this point in time. And the gaps in control that I've itemised there have led to the need to put in place what we're calling a clinical governance roadmap, which I will come on to in a moment. But if I can pause there, and happy to take questions from colleagues on the content of the risk, and then I can talk about the governance roadmap in a moment, if that's okay.
I received a letter from an MHK who had been reading the board papers and had seen the board assurance framework and corporate risk register and had misunderstood them as being a prediction of what will happen. So disastrous lack of staff, poor patient safety. And I met him and assured him that no, that isn't a prediction of what will happen. It's a prediction of what could happen if we didn't take appropriate steps to mitigate those risks. And it is good, normal, modern management practice to have systems like this in place, which he did accept. But I think it's fair to say that when Manx Care was created, we didn't inherit any of these systems. They've had to be built from scratch. And the point that you've made in that some of these gaps in controls are due to the newness of the organisation. So has anybody else got any questions about Andy? Yes.
Paul, you mentioned when under the, if you like, the exec oversight, you mentioned there are committees in place for social care and acute care, but does that also extend to primary care at this point as well?
Yes, it will. Absolutely, yes. It's for the whole of Manx Care's operation.
I just wanted to be sure, because they were, in case they were kind of like, the last one was anything disregarded. I didn't think you would, obviously.
Yeah, no.
But I just wanted to bring it in.
No, I think it's a good point, and you'll see that from the way we oversee the care groups. We see there is a care group that has primary care within it. We are, as you know, making steps to strengthen that and have a bit more of a direct focus on it. But yes, it's included.
Thank you.
Okay, anybody else? Yes, Andy.
Thank you. Just to say that over the next 3 months, as the current financial year draws to a close, I'll be working with individuals around the table and Elaine and your board committees to ensure that as we start early April with the second mandate, we have an assurance framework that references the likelihood and the impacts of failure to achieve those objectives set out in the second mandate.
Thank you. So, Paul, do you want to go on to the clinical governance roadmap?
Yes, thank you. Yeah, and so as you can see from the gaps in control, it's important that we take stock of them and figure out how we prepare ourselves to strengthen our quality control and clinical governance arrangements so that they optimise the best outcomes for people. We have pulled together a 10-point plan, which is in your bundle. I don't propose to go through the whole plan, except perhaps to socialise with you what's in there. There are 10 points. It does not seek to cover absolutely everything, and it would be foolish, really, to commit to do that within the first year. But I do think these represent the most important things that we need to get in place as the foundations for moving forward. Just bear with me one second. So if I could just sketch through my way through the 10 points just to explain what they are, and then I can tell you where we're at in the second month of the year. The first and most important thing I wanted to try and achieve through this plan is that we put ourselves in the best possible place for CQC inspection, which is coming in 2022. And on behalf of the Board of Directors, strengthen and support the Quality and Safety Executive in its duty to examine and scrutinise the quality of care across Manx care. So having the right kind of work plan, the right kind of focus, enabling and encouraging colleagues to challenge the information they receive and to prepare information that is meaningful and helpful to people who have the responsibility to oversee care. And to establish what we call a governance support unit, which the name is obviously subject to discussion, but I'm referring to it as the governance support unit for the moment. And it will bring together the corporate functions which hitherto have focused on certain elements of the business. But I'm bringing them together as one so that they can start to learn from each other and we can get more value from the economy of scale. So that is well underway. And I'd like us to get to a point where we've got consensus as a board on the risks. So when CQC asks the question of each one of us individually, what are the main risks facing Manx care, we are able to describe the same set of risks and, more importantly, able to describe the control framework for how we mitigate those risks. So this plan will help us to achieve it, and there are 10 points in there. The first one is to establish the governance support unit, and in your bundle of papers you will see an update for month 2. Good progress is being made on this. The second area is around risk management, and I would say we need to develop the capability right across the whole of Manx care to understand risk as a proactive, anticipatory concept. Unfortunately, most healthcare people understand risk as an incident, and they deal with things that have happened in the past. What I would like us to do and encourage us to do is to stand in the future and to anticipate the risks to the strategy that we have and to mitigate them so that we optimise success as far as we're able to and minimise the chances of things that could go wrong going wrong. To do that, we need to build a risk management process, we need to build a risk management strategy, we need to install a risk manager to help colleagues focus on their risks. And the emphasis when we have those things
together, meeting very regularly, and we have done a huge amount of work already in terms of the input into the mandate and the strategic intent documents. So just to assure the board, I'm working very, very closely with Karen and DHSC colleagues. In terms of COVID, we had a very busy period over the New Year period. We saw an increased number of cases. That was sort of anticipated, and we are starting to come out of that now. In order to manage what was very high staff absence, we peaked at around 15% staff absence during that period. We did take some action in accordance with our business continuity plan to reduce outpatient appointments, converting some face-to-face appointments to virtual appointments in order to release some staff to support the wards and mitigate against that high absence, particularly seen across Nobles Hospital. Manx Care continues to be a very active partner in terms of the government's COVID response, and we are now a member of the National COVID Response Group, which is giving us an extra opportunity to input into those wider debates. And as you will have seen, the government has signalled a stronger move to moving down towards level 1 and living with COVID. In advance of Christmas, we absolutely ramped up the vaccination programme, so delivering around 2,400 jabs per day in the lead up to Christmas. And again, my report makes reference to the number of additional healthcare staff and administrative staff who supported that. And I would just like to, again, for the board to note my personal thanks to the staff who absolutely contributed to delivering a huge programme just before Christmas. That has tailed off. I think the message is still clear. We absolutely encourage people to take up the vaccine and the booster, but we have now moved to a more roving service and looking at a mobile vaccination centre in order to provide that very local response and target isolated communities as well as the Chester Street hub. As we discussed at the board pre-Christmas, there has been a formal move. The 111 service is now part of Manx Care from the 1st of January. This gives us the opportunity to align the booking service with the swabbing service, and over the next 12 months we'll start to look at that 111 opportunity to align more strongly into our urgent and emergency care transformation plans. Just picking up on a couple of aspects of the Horizon scan, we've obviously had a real concern about the waiting list that Manx Care inherited across all areas, both in terms of acute care but also mental health and dental services. But we are making progress now to respond to some of those challenges with additional funding placed into adult mental health services to reduce the waiting list, and also commencing the Thrive programme in CAM services, which is a move to a more early help and intervention approach, working closely with education. So we have a new CAMS manager who has started with us recently, and project support going in to support that Thrive programme. I'm also really pleased to announce that we will be starting a recovery college for adults in the spring, and the executive team are due to receive an update on how that project is going. But I also had the opportunity to visit Manx Therapeutics community last Friday and see some of the work that one of our third sector partners is doing around developing therapeutics community, linking really strongly with some of the work Sally's doing around those local area hubs and that asset-based approach in the communities, which we strongly endorse through our ROF. We've also got a new head of ambulance service, William Bellamy, and Sally has made some key appointments in social care around those assistant director posts. So I'll pause there and take any comments or questions on the main report before I then move on to the Q3 ROF update.
Doesn't seem to be any questions at this stage, Teresa, so do you want to carry on?
Okay, thank you. So the required outcomes framework was the document that we wrote as Manx Care went live, which identified some of our key priority areas, and we've been tracking this on a quarterly basis through the board and providing information up into DHSC to support the mandate assurance process. Now, in terms of improving patient safety, a number of these programmes of work Paul's already covered in quite some detail, and they do read across and formulate into the governance roadmap. I think it is just worth noting, though, we have now got a signed off patient service user and carer experience framework, which we're using across the organisation. We've also got a new revised serious incident investigation framework policy in place. We're continuing the work on theatre improvement, so we have completed phase 1 and phase 2. Phase 3, which we have just started, is our response to the Association of Perioperative Practitioners audit, which was conducted in September. The report arrived with us in November. I'm pleased to report that that report gave us around 80% RAG-rated green indicators across a number of the audit areas, 20% amber, and there was no red areas of concern in that audit. So the action plan to respond to that audit is developed, and we'll consider that later in the board. So I think we're making really good progress on theatres. We still have the workforce challenges, but we are also making progress there and have been able to make a number of appointments to key roles in anaesthetics and support staff. We also have signed off the access policy. I think this is a really important policy for the organisation as it governs how we manage our waiting times and respond importantly to a number of those CQC indicators, not least the responsive indicator. So a clear policy framework for our clinicians to work in, transparent for our patients to understand, with a focus on clinical and management validation, and we will then move forward through that and look to have a programme in place which will start to transform the way we deliver outpatient services. Digital is a huge enabler to that, and I think that is where we need to have further discussions about the digital support we can expect to have or need to have in order to really make inroads into outpatient transformation. We are making some progress on reducing our overall length of stay in hospital. We are an outlier, but the work that we have done around putting in same-day emergency care and pre-hospital decision-making are priorities for us and are reflected in our mandate going forward. In terms of improving patient safety, the only area rated red is disability strategy, and I don't know whether Sally would want to say anything more on that, but I think that is just a timing issue. In terms of the workforce and culture position, I think we're making some really good progress here. We're working really closely with the workforce and culture team. Part of that is having really good governance in place. We've got our new induction programme working well. We have just revised our visions and values for the organisation, and are in the process of developing a comprehensive communications engagement strategy, which is not just with our staff and an internal document, but moving that out to a much broader piece where we start to have a broader engagement with the public. So I think, in summary, I think we are making really good progress against the ROF. Certainly we had a board-to-board with the DHSC yesterday, and I think they're suitably assured that we are making good progress. I'm happy to take any comments or questions on either the theatre update or on the ROF action plan.
I think Andy wants to come out on this, but I think we just should comment on the two risks that are red rated here. So Sally, do you want to pick up the first one?
I think the first one, in terms of the learning disability strategy, the learning disability strategy has been completed. I think what hasn't been completed and we've failed to recruit to is the autism strategy that needs to be developed alongside that. And it has just come back. We've failed to actually commission a service for that, so we're going to have to look at a different way of doing that, and I suggest we do that with our third sector partners. The LD strategy, however, although that was completed last year, it does need review. It's a very wordy, lengthy document, and I would personally say it doesn't aspire enough for our adults and children with learning disabilities on the island. Again, we are going to work, we've got plans to work with our third sector partners to review that and to make it a bit more accessible. Like I say, it's very wordy, needs to be accessible by people with learning disabilities.
And if we just come to the CIP quality impact assessment, so we put in a CIP cost improvement programme last year. It sort of started to mobilise midway through the year. There is a quality impact assessment framework which sits with that, which we have agreed and is in place. But I think where I would indicate that we are red, and I'll perhaps ask if Shri and Paul wanted to contribute further on this, is we haven't got into that practice of routinely assessing every CIP for the quality impact assessment. So that sort of strength of the governance process around our CIP needs to be strengthened in order to ensure that we are making the right decisions and we are assessing the impact of any cost savings that we make. So I think it's there's just the maturity of the system which we have had to put in mid-year. But I'll invite Shri and Paul to maybe make any further comments on that, or perhaps Jackie.
Who wants to go first?
So I'll take it on. First of all, I think cost improvement programs is about the efficiency, and the efficiency is being underpinned by the fact that we have got risk with workforce, which we talked about. There is quality and governance that Paul's kind of narrated about what the framework we have. So that is the reason why it is in red. So unless we get into the business of getting workforce and quality embedded into it, there's going to be some risk associated with kind of outcomes of the cost improvement programs. But having said that, I think it's quite important to note that for the first time, for the first time for Manx Care, now we got a IMOG, which is an Integrated Medicines Optimization Group, which looks at drugs that are being prescribed across the island, so that there is one single committee which looks at prescription of drugs that is that we can actually rationalize for better care of the patients across the island. So it is, I think, it's a step forward in the right directions, and to realize the cost and efficiencies, it will take time. But I think I'm confident that there are certain elements of the cost efficiency programs that will realize in the coming future. It will take a bit of time, but I think we are very confident that it will realize it. And that will also feed into the required outcomes framework of how we spend the drugs in it. So from my side, that is the only thing, unless Jackie wants to, Jackie is kind of...
Yeah, so just in terms of the quality impact element of the SIP, is that I think there's been two pieces of governance missing in the governance framework around SIP. The IMOG that you referred to, Shri, and we've had some difficulties around resourcing that, and I'm really pleased that that has now resolved itself, and as you say, the IMOG has met. The second piece of work was around establishing the SIP programme board, which is designed to basically take that overall responsibility for governance and monitoring, so taking that performance management and quality management role on board, and that group is due to meet next week. So I think I'm encouraged by the governance that's being put in around, at the moment, the formal governance. But what I would say is that in terms of all of the SIP programmes and the work that's been done so far this year, is that whilst formal quality impact assessments have not been carried out, certainly clinical guidance and clinical approval for anything that we've done has been sought and received before we do anything. So there's a number of areas, particularly in our SIP, where we've targeted certain things, particularly around prescribing, and haven't actually progressed those, despite the fact that there's lots of documentary evidence to say these would be normal things that one would do in the system. Without that clinical approval of that, the SIP programme has not pushed forward on anything. So that's been where we've governed ourselves, but not in a formal way. But I'm pleased to report that I think that the governance is improving, and will continue to do so.
Yeah, thank you. Yeah, but for my part, I think this might be my naivety. I haven't been asked to sign off an impact assessment on quality since I've been at Manx Care. And it's helpful to see it as read, because I think I will give it more attention and ask questions so that I can be involved in that process more directly.
Okay, thanks. Andy?
This is a small point. It's under section 1.9, which is the developed plans for the 0 and day 1 length of stay changes. And I think it's due to go back for to transformation at the end of Feb, is that right? Yeah, 28th
yes,
of Feb.
the wider...
So are QSE or the board going to get the opportunity to scrutinise that before it finally goes back?
The urgent
Or is that
emergency
not
care
necessarily?
business case. I don't think it's particularly necessary. I think it probably comes back to the point Paul makes, that a lot of this is around those basics, safe staffing, plans for diversionary schemes and pre-hospital care. We could perhaps give further consideration in the exec team about whether any board subcommittees feel the need to have scrutiny over that. But as it stands, it has just been tracking through the exec team and the transformation oversight group. And I don't think there are any concerns being flagged from a quality and safety perspective that feel it would need that broader scrutiny. But I'm happy to revisit that with the executive.
It's just a piece of reassurance that there wasn't anything lurking in there, really.
Well, I think your question is a helpful one, actually, and I think it will prompt us to make some more inquiries. I mean, I think our exposure to the risk of extended length of stay is lower than my experience elsewhere. But for people who have an extended length of stay in hospital, there are safety considerations that you need to take into account, because it's not the most safest environment for some of these people to be. And I think we need to be pushing more to get people into the appropriate venue of care as quickly as we possibly can, to minimise the very real risk of deconditioning, which is a problem for many people.
Okay, well, it was just literally maybe just the consideration.
Yeah, that's a good question, actually.
Thanks. Any other comments or questions? No? Okay, right, so do you want to move on? And that, so that covered both, that covered the theatre action plan as well?
Yes. Yeah.
Okay. So, committee chairs then, please. Sarah first, QS&E.
Thank you. So the board will note that we didn't meet in January due to quoracy requirements, so we'll be working hard to make sure that we are quorate for our next meeting. It was just for the board to approve the policy that's attached to the papers. So that's the policy for the formation, ratification and management of Manx care policies and procedures. A snappy title, you'll note. Yeah, we need formal approval of that document. I'm just looking at Elaine to make sure that I've put that correct. Yes, thank you.
Right, and then when we do approve this, if we do approve it, I think, how many did you say that you've come across?
There are about 1,900 documents for us to work through as possible.
Goodness me, sure. Oliver?
Thank you, Chair. So I've read through the policy, which is essentially, I think, a policy for creating policies in Manx care, which seems like a very good idea. Again, this is something that the primary care network has been sort of, I think we're not as far along as you are, but trying to create a system and a policy for creating policies within general practice and primary care. And certainly one of the things that we've been thinking very carefully about is how, if we were to make a policy in primary care, or if the primary care network were to generate a policy, how would that impact on our partners in Manx care? And thinking about how that kind of, we need sort of like a double sign-off type thing. And I wonder if the board might consider how, for policies which are developed in Manx care but will have a great impact on primary care and general practice, how we can make sure that we're aligned and we're all sitting on the same page.
Now, to help with that, Oliver, I would suggest that it's really helpful that you're at the table because you'll get awareness of some of those things. But one of the ways we can help mitigate against that is that we have a really robust consultation and a very open, dynamic process for working through differences of opinion or perhaps how things work in practice. And that will take us to a point where the documents that we authorise are authentic, they're properly validated as being in place of Manx care and usable, and we can be confident that they've been road tested to some extent and that people are confident that they will work as imagined. And I think that's the most important thing about these documents, is that they will work as we expect them to work, rather than just write something that we impose that then doesn't work in that way. So your input involvement in that, as the input and involvement of everyone around this table, will be crucial.
Can I come back? Can I just come back?
You can, but I just want to agree that your very presence here today is the beginning of giving visibility between primary and secondary care. And as you know, we'd like to take that further and deeper, involve more of your colleagues so that primary and secondary care work ever better together. And it did come back.
No, I think that's very encouraging and that's very reassuring. And I wonder if there's ways we can sort of strengthen that consultation and perhaps even formalise sort of a framework for that consultation to take place, so that we know that that the right people out with the Manx Care Organisation have been consulted.
Yep.
Yeah, perhaps it's appropriate to give some consideration to primary care representation on some of our board subcommittees.
That is indeed this one. That is indeed the ambition, and Oliver is not going to sit just on the Manx Care Board. He's also going to sit on the Executive Management Committee as well, and we do anticipate engagement with other primary care representatives too. This is day one of that. So, yeah. Sri, did you want to come on that one?
Yeah, I was just going to say, just for kind of clarity, the whole idea of having a primary care network is to provide a personalised, integrated care closer to the home for the patient, and that is only possible if policies are joined up and work together, and it is an integrated care. That is the only way forward. So I think you're absolutely right, Oliver, that I think the policies should be joined up and it should actually speak the same language, and it actually means the same for the patient as well. So the working together is essential so that it flows continuously. The pathway doesn't have any kind of fractures anywhere. Thank you.
Can I then take it that we're going to approve, sorry, you go first, Katie, I was going to ask for approval of the policy.
I'm sorry, Chair, just a minor
Yep.
point. On the document template, right at the end, I'm very heartened to see that there is a section making sure that the document conforms with equality and diversity legislation. Can I just make the point that not everybody who is writing a document would necessarily know what the legislation is, and so we just either need to make sure that document writers are trained in that, or we have a check and balance to make sure that somebody goes through it to make sure that it's conformant with the legislation.
That's a good point.
Thank you.
As applied on the Isle of Man.
As applied on the Isle of Man,
Yes.
and it does say Isle of Man, yes, legislation. So I just need
Okay.
to make sure somebody is
Yeah.
cognizant of that. Yeah.
It's a good
There
point.
is a small point then that training is available online in Lead, in fact, specific
it?
to the other
Oh,
man, yeah.
Oh, fantastic. Okay.
Very good.
I believe there is a course.
So with that comment, can I take it that we can approve this policy of policies? I can't see nods, so I'll take that as approved. Thank you. Right, so next we're on to Nigel.
Andrew, thank you. Good morning, everybody, again. So Finance Performance and Commissioning Committee met on the 17th of January. We meet monthly. These are not dull meetings, folks, if you don't come to them. They're lengthy. It's a workhorse committee, and we consider the numbers. And I view the numbers as part of the story, that one crude way in which we measure ourselves. But nevertheless, it is important, and money is a huge lubricant, not necessarily a propellant. So we do need to measure ourselves. One of the things I consider we must do is also prevent you getting surprises that you don't want to get. And I think I would like to pay particular tribute to the finance team in the way in which the numbers have been reported. Jackie will talk to the agenda later on in our meeting about the management accounts. But I feel and perceive that arguably with the work that was carried out in the autumn, in terms of addressing key lines of inquiry from the department, our stakeholders, and the Treasury, that we have a real grip, arguably for the first time, on what kind of a beast we've inherited in terms of the way in which the money flows and it works. And I think it's fair to say that we didn't necessarily know what we'd inherited, but I think we have now identified what we inherited, we've accounted for it, we've drawn that story out, and we have a good base from which to go forward in where we can start to exercise control and look at ways in which we might gain those efficiencies and value for money that was envisioned and envisaged by our work and by the Sir Jonathan Michael report. So I'm very encouraged by that. And I think that's sort of setting the scene. The other thing that I think this report should do is not slavishly deal with the items that we've got in the agenda, but give you a flavour for what went on in the Finance Performance and Commissioning report. And there is a story of evolution here. And the story of evolution that I want to pick up is many of the points that Paul has raised in terms of the standards and the procedural work that's been going on, in that every action has a reaction. And every action that we take here will have a reaction somewhere else. And it will be ultimately reflected in the numbers, either in cost or in value or in optimization. And I think that's very important. And one of the key issues that we discussed at the committee was how we can use the impending CQC inspection to bring about and help us manage change more elegantly and more efficiently. And that's with the introduction of the so-called CLOEs, or key lines of inquiry, that are an imperative and a necessity for us to meet CQC requirements, but also is a fascinating and useful tool in the way in which we manage our resources going forward. And it was thought that the Finance Performance and Commissioning Committee, as part of their work on integrated performance, should also have sight of the so-called CLOEs. And we felt that colleagues in the service need more meetings like they need a hole in the head. And so therefore, how did we actually get sight of the so-called key lines of inquiry that would develop as we went forward? And we discussed and agreed that the way in which we do that is we would do it through the performance and accountability review meetings, which already take place. They're deep dives into the care groups by the executive, and rather than have the executive present again to the finance committee and answer questions on key lines of inquiry, we would actually go to the performance accountability review groups and enable some of the DNA that goes on within the finance performance and commissioning meeting to integrate and inculcate within the performance and accountability review groups. It would also give us hands-on experience of meeting people at the coalface, and vice versa, give them an opportunity to meet us as non-executive directors and as key members of performance, accountability and commissioning meeting. So we are, I'm very encouraged by that. I think it's a very exciting development, and it will enable us to start to, if you like, drive down the culture and ideas that we are discussing at performance and main board upwards, downstream in the performance accountability review groups. And that I felt was a very positive aspect of our recent meeting, and we're going to be developing that as the year unfolds.
Thanks, Nigel. I'm glad you mentioned the key lines of inquiry, because I think that's giving a level of sight deeper into the organisation than the board normally sees. And
absolutely, as well as the sort of regular deep dives into the care groups that we're planning.
Sure. Thank you. So next is People Committee. Sarah?
Thank you, Chair. I'll take it as read in terms of people's understanding of the pay negotiation issue. I did want to pay particular tribute to the member of staff who came to the committee to give her experience of working at Manx Care. It was both incredibly inspiring and quite motivational, and she was a very hard-working woman who had a family and had managed to get a first-class honours degree during lockdown, as well as doing her full-time job. And it was absolutely wonderful to hear from her. And we were encouraging her to encourage her colleagues to come forward because, as we've said many times before, there's nothing quite like hearing directly from a member of staff. And I think she had quite a good time at the committee, so hopefully she went away and told people we were warm and welcoming. And then, as discussed yesterday in our board-to-board with DHSE colleagues, it was good to hear from Locate Isle of Man about the potential to really increase our activity in promoting the Isle of Man as an attractive place to come and live and work. And we did have a discussion about kind of recruiting couples and families and family units, not just going after one individual perhaps to come and work for the for Manx Care, but looking at whether there were partners who could work in police or education and so forth. So that was quite an encouraging conversation. We do need to keep our focus on what is our ambition for ED&I, and what does that look like, and what do we want Manx Care to look and feel like, particularly around the area of inclusion. I think we've got clarity around equality and diversity because of our legal requirements, but actually that, how do we make people feel really welcomed and really included in the culture of Manx Care. Attrition is well known to the board. I won't spend any time on that, but the IDEA scheme, we discussed the reward scheme. The team of the month is going down really, really well, and so perhaps the next step there is to think about how we encourage colleagues to come forward with ideas and how we build that into a reward scheme. Thank you. Happy to take any questions.
Thank you, Sarah. I don't see that there are any questions, so we'll move on to Katie for data and informatics.
Thank you. So there's a theme developing here. One of our red-rated items in the D&I committee was recruitment. So lacking staff in the business information area, so that's having an impact on some of the programmes. So it's good to, I'm at the People Committee as well, so it's good to understand how we're trying to improve things in that respect. One of the hugely cheering pieces of news was that the clinical alert system has been rolled out. This means that the patient care potentially is going to improve because the ability to get hold of any medical personnel should be improved. We tested the technical aspects of this, making sure that there was a good failover to 4G in the event of a Wi-Fi outage. We were assured that not only was that the case, but there were also signs going up about black spots for essentially making sure that if somebody was in a stairwell, they knew that potentially that they couldn't be contacted. So there's been some real effort there to reduce risk around clinical alerting, and we were heartened to hear that. So that was a really cheering piece of information. And then also we heard about the Information Governance Advisory Board that has kicked off, which is going to be key, I think, to our committee as well. So we will be seeing the results of that at the committee, but also I think we'll be working hand in glove with the people who sit on that committee. So those are the two biggest items for me, if anybody has any questions.
We have two for the price of one from you. It says here mental health legislation, which was last week, wasn't it? But you also have the audit committee report too.
Yes, mental health. Okay, let's deal with mental health quickly first. So remind me, Shree, if I forget anything briefly. I don't think it's actually here, is it? So can't remember what
Section.
Oh, section 1 to 8.
1 to 8, and also the section working on
115. Yeah. So work continues on section 115, which is our aftercare costs. So just as a very brief reminder, basically we, Manx Care, are responsible for all costs associated with someone who's been sectioned and then released and requires aftercare, and that includes hotel costs, irrespective of their ability to pay, and that's essentially unfair on some members of society. And it equally means that as Manx Care we have no control over that, and we've had significant additional costs in this year. I think we had to allot about an extra 800,000, is that about right, to cover it? So that is a very significant uncontrolled cost which we need to address. So there is a working group looking at the 115 regulations. It's within our remit. We will consult with the AG's chambers, obviously, just to ensure, but we don't believe we need legislative change to bring that back under control, but a policy change from Manx Care's point of view. So that's being driven forward at the moment to help us contain costs. There's a comms piece to explain to people, particularly as that will mean changes for some in our community. So that's ongoing at the moment. Section 1 to 8.
and also the mental health commission report.
Thank you very much.
Yes.
So let's deal with the Mental Health Commission report, which was the one for. I'm terribly sorry. I'm really having trouble remembering this.
The unscheduled visit to.
I brought my other notebook and I didn't have a chance for the notes. So the Mental Health Commission, there was effectively just some outstanding actions from the report from October. That Manannan Court, they've largely been dealt with. The arrests are under control, so we were assured quite substantially that things will be fully in place in the near future. And section 128, which is about arrest and being taken to a place of safety. So this is someone in a public place who clearly exhibits what appears to be a mental health issue. It's a police power of arrest. The normal practice is that that individual is transported to the place of safety by ambulance, because the paramedics are trained to make that point assessment to ensure that they're taken to the correct place. So if they need, for instance, urgent health care, they're taken to A&E. And if they don't have urgent health needs, and it's the mental health needs, they're taken elsewhere to effectively to the to a safe suite on one of our premises. Unfortunately, with ambulance delays and so on, it appears that that has switched over to 60% of the cases are being transported by police car to accident and emergency, and that's not satisfactory. So work is underway through the regular contact group with the police to try and resolve this, and obviously it will involve some effort from the ambulance service as well, potentially. I think those are the key items, are they not?
That is it.
Thank you very much. I
That's good.
apologise for
just for the sake of clarity, the because that meeting only took place last Friday, we haven't got a written note of it
No,
yet.
we don't yet.
So,
No.
but we do have the note of the audit committee. So.
And I had been warned about remembering to do it verbally. Thank you, Elaine. But unfortunately, it just slipped my mind with everything else.
Don't worry.
Okay, the audit committee. So the audit committee is trying to play catch up after a relatively long delay. So we're meeting monthly rather than bi-monthly or quarterly. As mentioned elsewhere, we are conscious of CQC on the horizon, the preparedness for CQC. So part of the audit committee's role is to look at all of the outstanding items from the other committees and the minutes to make sure that effectively we are preparing and we are seeking assurance over the next few months to make sure that happens. On other items, we were aware that there is a very, very long list of unaddressed audit outstanding recommendations inherited from before Manx Care came into place. Some of them going back and apparently unresolved to about 2017. That list extends to about 250 apparently unresolved recommendations, many of which are likely to have been superseded by changes in policy and so on. Internal Audit have kindly gone through them and analysed them for us. We need to sit down now, analyse them and decide which ones we would pass on. Our single point of contact at the moment is Teresa. Hopefully there won't be too many from that particular list that need to be addressed, but obviously, you know, we probably will need to seek assurance on some and continuity on others. Internal audit plan, there's a key needs assessment, and effectively that's on the way in the next month, so we will have our audit list and then we're done. And at the moment, one of the other concerns we raised was whistleblowing. With the departure of our permanent board secretary, we didn't have an appointed whistleblowing contact, and that is a significant concern, I think, from a governance point of view, and that needs to be addressed urgently. Thank you very much.
Thank you. Again, well, that's the report from all the committees, so thank you very much for that. Did you want to...
No, I would just want to probably endorse the work and give assurance that I think it is entirely right that we go back over all of those previous audit recommendations and absolutely assure ourselves they have either been fully actioned and implemented or superseded by something else, or they no longer apply. I think we've had examples, and I would sort of point to Sally, who has almost done a bit of an amnesty about previous recommendations from reports across social care to ensure that we have absolutely tracked back everything and ensured that we have put in place actions as a result of those. You know, I know we've inherited a number of audit reports, and a number arrived just as Manx Care were being established. But it's an action I think the executive feel is important to give the assurance to the board that we have looked at everything, re-looked, and we have plans in place to address any recommendations.
Right, we are uncannily on time. We were uncannily on time. Nigel.
Just one point, if I may. I've sat on a number of audit committees over the years, and as Andrew, our chairman of our audit committee, said, we're playing catch up. I would just like to pay tribute to the audit team within Treasury, actually, because they don't belong to Manx Care and they do work within government. And it's a very fine dividing line that you walk when you're an auditor, because you're looking for assurance, but you're also pointing out things that could be done better. And the list that we've been provided with has been immensely helpful, and it will cross the line from audit recommendations to actually assisting us with the management of Manx Care. And I think this is incredibly important, and I absolutely applaud the way in which they've done this. It's been immensely helpful.
Definitely a point worth making. But we'll now take a 10-minute break, people. Please be back for 10 past.
Yeah.
Thank you. Okay, we'll start again then. So welcome back, everybody. Teresa, over to you for the Integrated Performance Report.
Thank you, Chair. So there is an executive summary to the Integrated Performance Report, and I will probably also invite Sally to cover off the social care indicators. I guess an apology to the board that I think we'd have hoped to move across to the new business intelligence format for the report for this time, but that has been slightly delayed. But progress continues to be made in terms of moving to that automated system, and Richard may also want to comment.
Can I just interrupt on that point? When we do get the automated report, will it be, so for example, this is the November information, will it be the December information?
Richard, can you advise whether that's...
Address your point, Teresa, in terms of why we're not seeing the automated version today. This has been a lot of staff pressures, and trying to get operational staff to go in and validate the data in the reports has been quite difficult over the past 6 weeks or so, but that's something we're going to be focusing on now, hopefully during January and February. In relation to the timing of the reports, the timing of this board comes at a point where it's very difficult to validate the manually collected part of the report, but the automated part of the report we absolutely can have live up-to-date data. So we'll actually have a hybrid where we'll have some in-month and some from the previous month, but it'll be very clear in the report which is which.
Okay, so this report does cover November 2021, and I hope the board can see that the sort of some of the key areas of performance concerns are being mapped across into the CLOEs which inform the performance and accountability reviews. So, for example, our emergency department performance out of hours and the performance on the ambulance service was two of the key areas of discussion for the medicine urgent emergency care group at the performance and accountability reviews on the 18th of January. So just to sort of pick up a few bits of the report, obviously in November we were running with reduced theatre capacity due to our workforce challenges, and I'll say a little bit more about that in the next update. But obviously we were running an elective programme which only really allowed us to cover emergencies and cancer cases. We are starting to build back the elective programme. In terms of other planned care, I think it's really encouraging to see that we are starting to see the number of patients with a long length of stay reducing. So on page 116 you will see that the work we are doing to identify complex discharges, put discharge planning in place at the earliest opportunity, is starting to have some impact on the number of patients who have a long length of stay, and we've seen a genuinely a month-on-month reduction since July. Our DNA rates across outpatients are still very high, but again we've got a real focus on this in our access policy, and we definitely want to move to patient-initiated follow-ups, and we're looking at a text system which allows patients to be reminded of their appointments, because on the whole a sort of 9% DNA rate is a lot of capacity lost from our system that we could utilise. Just moving on to urgent and emergency care, again the executive is concerned that we have dips in performance and a lack of resilience in the evening and overnight periods within the emergency department, and have therefore taken the decision within the funded establishment to recruit an additional ED consultant, which gives us greater coverage of ED senior decision making in the out of hours period. We have recruited a new head of ambulance service who started at the beginning of January, who brings a huge amount of experience from the UK. And he's currently doing workforce planning and looking at how we make the ambulance service more resilient. I think an important point which we discussed in the performance and accountability reviews is that the ambulance service has a pretty much similar operating model of how many vehicles it has on the road during the day and the evening period to that level when it was first established. and demand has significantly increased. So I think we are needing to do a very comprehensive review of the capacity our ambulance service needs, but also the unnecessary conveyance journeys the ambulance service has to be involved in. So the focus we have already started through the urgent and emergency care business case, but will be translated through to a more focused piece of work in the next 6 months, is around that pre-hospital clinical decision making and those diversionary pathways which allow patients to not be conveyed to hospital unless they need to, and directed into other pathways and services. Because at the moment, if someone requires an ambulance, that is not clinically challenged, an ambulance is sent. And that is meaning that our service is probably not prioritising the most critically ill patients who definitely need that response. I think it's also important to note, again on page 124, that our medical out-of-hours service, the MEDS team, is working very well with very good performance against calls back within that 2-hour period. On integrated cancer and diagnostic services, again, I think we have seen increased performance around 2-week waits. There is still further work to do. I think the graph on page 130 really demonstrates what a significant increase in demand we are seeing across the 2-week wait pathway. I think that is mirrored. It's not unique to the island, and it's also something which we shouldn't be concerned about as we promote early identification and detection of cancers and put those public health messages out. We absolutely would expect to see increases in referral rates. And I also think it's a symptom of growing confidence in the service that we are starting to respond to 2-week waits in a much better timescale. And if you look at where we were in the summer to where we are now, there has been a significant improvement. I also wanted to just highlight that there has been progress around the number of patients waiting for a dentist. So significant work has gone on in the team, and that has improved significantly. So I'll perhaps hand over to Sally just to pick up on any KPIs around social care, and then I'm happy to take questions.
Thanks, Teresa. There's just a few points on children and families. It's really good to see that the number of Section 46 inquiries, which are those inquiries around child protection, is coming down. It still needs to come down more. The re-referrals, although we're seeing a month-on-month reduction, is still too high, so we need to keep an eye on that. It's going to be really good, or it's been really good to see the quite an increase in the number of referrals to early help and support, and it's going to be interesting to actually watch that over the next couple of months to see whether the correlation between that and the Section 46 referrals actually carry on going in the same direction. So that means that we're getting the early intervention and prevention in before actually children are ended up on child protection conferences. You'll notice that the conferences and reviews held on time is quite low. It has been for the last 3 months. That is directly correlated to COVID and the loss of staff that we've had. And can I just point out, when it says conferences and reviews held on time, although it's low in terms of been held on time, they are still happening, just not happening on time. Adults still continues to work that we need to do with the BI team. There's still issues with duplication, with referrals and re-referrals, and that's partly because of the KPIs that we've been looking at, but also Rio, the system, is not good for generating. So quite a bit of work has gone on with the BI team to sort of see how we can actually improve on that. I don't think there's really much to say about adult social care. It stays the same picture. We're seeing low uptake on some of the beds within some of our care facilities like Cumulmore. Some of that has been COVID, but the majority of those buildings are not fit for purpose.
Okay, thanks both of you. Chairman, would it be okay if I just made a few comments on the quality measures at the back
of the IPR there, because I think there's some important things to acknowledge. I think it's really helpful and encouraging to acknowledge that we're making good progress on some of the what we call alert organisms, so MRSA, Clostridium difficile. we've got low incidence of those problems throughout November, and actually in Q3, which I think is really encouraging. And also in relation to the incidence of falls that involve moderate harms or above. A fall is quite a common thing, and actually is a very common reason for coming into hospital, but falls whilst under our care involving harms is a very low incidence, which I think is very encouraging. I'm working on this just to make sure, but I think it's very encouraging, as is the incidence of pressure ulcers in our care. Again, compared to England, the number of reports is quite low. I am intensifying my scrutiny of medication incidents. We have had a small number of medication incidents compared against a number of medicines interactions. And I'm focusing in particular on what we call the high-risk medicines as part of our scrutiny. But we've had a few events which have resulted in no harm, but we've got a new group that Shri referred to before, a medicines optimization group which deals with medication safety. And in that environment, we're going to apply a little bit more scrutiny of these type of events to make sure that we've got them properly under control. And you can see from the information in your pack, the information on complaints which gives impetus to the points I was making before, about the need to be more responsive, about the need to be quicker, and take on board the feedback from service users. Most of the service users that have cause to complain about waiting times and delays in treatment, followed by people who have complaints about the standard of their care. And those are things which are so important to me that I want to make sure I get on top of those. So I just thought it would be useful to comment on those, Chairman.
As you mentioned the point of falls, I see that there are two tables for falls. One is inpatient, acute inpatient falls, and the other is presumably overall falls. And I think they are all falls rather than falls with harm.
They are indeed, yes.
Yeah. So do you separately have the information, or you must have the separate information on falls with harm?
I do. I interrogate particularly the falls with harm. Yeah. I also look at the falls that don't have harm with a view to where there might be risk factors that we can work on, and that's an area that we are just about to get into across Manx Care with a new clinical expert on that.
And again, the point I mentioned earlier on about benchmarking mortality data, the same would apply to benchmarking falls. You rightly make the point that falls are inevitable, but the number of falls with harm, in your experience, how does that benchmark to other organisations?
So with the information I have, and I caveat this just because I think I need to be more confident in the data, but at face value, the data would indicate that the incidence of harmful falls at Manx Care is considerably lower than might be experienced in a comparable organisation in England. But as I say,
that depends on it being reported.
I caveat that, yes.
Yeah, absolutely. Okay, thank you. Right, Andy.
I'm going to talk to the blind and the obvious, going back to the ambulance ED piece. So the thing that's missing from the commentary, and Teresa did say obviously there is a focus on ambulance to ED, but again the month that's reported, we did not manage to run on all our ambulances again. Oliver confirmed that in the Finance and Performance Committee. I've sent him some further concerns about data, which I hope he's addressing. But we had a commentary in the ambulance piece about ambulances not being able to offload patients to ED, but that is not included in the ED waiting time, which would increase the ED waiting time as well. So that's inadequacy. So basically we've got the call to the ambulance being delivered, the person being delivered by ambulance to ED, and the waiting time in ambulance and the ED waiting time. We've got effectively two rate limiting steps in there which are not adequately reported in the IPR, and I think I'd like to suggest to the board that we should insist that those are actually pointed out very specifically in the data. There's a change to the KPIs to accommodate that, because those are absolutely critical to, I mean, early harm, everybody knows. I don't need to go any further than that, really, I don't think.
I would absolutely agree that we do need to record the amount of time that patients are on an ambulance waiting to be offloaded. It's a standard which we're used to reporting very consistently and frequently across the NHS in the UK, and I think we have to sort of adopt that similar KPI. You know, I have to say again, and we don't have the data, But I also do know that the instances where an ambulance is delayed in being able to offload a patient into the emergency department is incredibly rare. And there is an escalation process in place to ensure that is addressed quickly. But I would absolutely accept your point. We need to include that in the KPIs for reporting going forward, and we will do.
Thank you.
Thanks. Sri, next.
Yeah, Chair, thank you so much. And Teresa, I just wanted to expand on the access policy, and I'd like to actually just focus on the fact that for the first, access policy has been implemented. This is the first time that Manx Care has got a fair, honest, transparent, equitable policy for the patients to access the care based on their clinical priorities with Royal College guidelines in the current environment. And I think the next steps are to actually find out what is the harm that is being caused to the patients when they're waiting for have this treatment, and that would be a part of the clinical harm review process, which we are training the whole of the staff, including the consultant workforce, to actually kind of document that and how we mitigate that risk as it was. I just wanted to bring that point as well.
Very good, very good. Katie.
Thank you. Teresa and in fact, Sri, you might want to comment on this. On the theatre utilisation charts, we've got obviously a target of 85% for utilisation, which we're just about hitting, which in itself sounds like a good thing, but clearly we know that the number of theatre sessions that there are available is very low. So I wonder whether we should have a target on the theatre session graph, as well as the cancellations on the day and the late start in minutes, because it's starting to get to the stage where I'm losing track of how many theatre sessions is optimal. And I know we came off a high of 97 in June, but it'd be great to have targets on those other graphs as well.
Yes, yeah, I would agree. You know, I think there's something about the efficiency of the sessions we do have available
yes.
to us. But then ultimately, and this is a really important part of our restoration and recovery plan, you know, how many theatres can we optimally deliver? What's our sort of maximum number? And then how many of those are we able to achieve? And that's, you know, that's primarily led by our workforce requirements, but that's a barometer of our ability to deliver comprehensive elective programme too. So yeah, I think we should include that too.
Should I just jump back in just momentarily, just to say some of the things that I've said in particular may appear a bit critical, but actually I think, to be fair, all we're doing now is we set up the KPIs at the start of Manx Care as a preliminary set, and all we're doing now is spotting the gaps. So I don't think there's any intended criticism as such. It's just trying to spot the holes, and I think Katie's just spotted another one.
Yeah. And I think, you know, it's all very, very fair, because we do want to, you know, we've done a huge amount of work on theatres already, but that has been focused on quality and the culture and the safety of theatres and understanding the workforce requirements going forward. We've now got the Afp Audit, and that's phase 3, and then phase 4, which we will start in earnest in March, is that efficiency, productivity piece, which is really important. But we needed to do that piece of work, having got some of those basics around quality, safety, culture, workforce numbers in a little bit better place, in order to sort of then move on to the efficiency piece, which I think we'd have liked to have started earlier, but was just not possible.
Sure. And, you know, we all see on our televisions the reports of the news of the UK where the ambulance delays are really, you know, queues of ambulances waiting to offload at ED, and patients having very long waits even for serious emergencies, which frankly, I mean, thankfully is not happening here. No. And then the questions on the theatre lead neatly into the restoration and recovery update, don't they?
Can I, sorry, Chair.
Sorry.
I know I've mentioned this before, and I know that it is a work in progress, but the women and children's section is still completely lacking.
Yes.
And so that remains a cause of concern for me. I know it's a cause of concern for colleagues, but I just, I'm struggling with that bit.
So I would propose that we do, you know, I think we did start off with a number of indicators in women's and children's, but probably felt they were not the right indicators. I think we need to go back and absolutely look at the indicators which would be reflective and we would want to see around women and children's services. So if we commit to do that for the next report that comes to the board, that would be great.
Could I add, Teresa, Sarah, for your benefit, in respect of maternity services, we have now built a maternity dashboard and we have started to backdate the data. It's still incomplete in some areas, but I think that will be hugely helpful to you and other colleagues.
So we'll see that soon, presumably.
Indeed.
That's Thank you. Yes. Sorry, Sarah, you're in my blind spot. You have to wave at me. Right. Okay, so can we go on to the Restoration Recovery Report?
Yes, and I wanted to just give a verbal update on this and I guess some assurances. As we've discussed and documented here, Manx Care inherited incredibly large waiting lists, which were partly due to COVID, but also I think there had been historic significant waiting lists with very high numbers of patients, over 4,000 waiting over a year for treatment. We subsequently put in additional business cases to Treasury to fund additional activity. And so I wanted just to give an update on that because it has taken a number of months to get those contracts all agreed, get all of the information sharing and governance arrangements fully in place for those to start. But we are starting to see the benefits of that work. Also important for our restoration and recovery is having sustainable workforce in order to deliver a comprehensive elective programme, so I will also touch on that. But just coming to the waiting list position, we targeted a number of areas. So we targeted endoscopy, cataract surgery, and joint surgery, orthopedic, hip and knee surgery, and then a broader piece on outpatients across a number of specialties. So just coming to endoscopy, that work started. It has been delivered by internal teams working extra sessions. And by the end of February, an additional 550 endoscopy procedures will have been undertaken and the waiting list reduced significantly. With regards to cataract surgery, again, we are working with a external provider of cataract surgery. The contracts are now in place and we will be starting to invite patients for pre-assessment during February, and that work will start in March. So at the moment we have around 1,300 patients waiting for cataract surgery, and this will deliver about 350 additional cataract operations from that business case during the course of March, and then we are preparing a further submission, a business case, to undertake a further 400 cataract procedures. In terms of orthopedics, again, heavily impacted by COVID and the fact that we could not dedicate a separate ward for orthopedic joint replacements, which is required. So there are currently around 530 patients waiting for inpatient orthopedic procedures, and we secured an additional £1 million to undertake hip and knee replacement surgery. This has to be undertaken off-island. In the short term, we do not have the capacity to offer that more broadly on island at the moment. So we are looking at offering choice to around 50 patients to be sent off-island to be done with an independent sector provider partner who we now have contracts in place with. We are looking to do a further 300 cases on island, again bringing additional capacity onto the island in order to deliver that work. And that will be done over the next 6 to 8 months. And then Medifa, who is our partner, which is a virtual outpatient service, that has recently started and across a number of outpatient specialties. So it's just to give the assurance that we are starting to see the impact of that additional investment in the work, aligned with the work on the access policy in order to clinically and administratively validate the waiting list. We should see the waiting list numbers come down. In fact, we've done some trajectories which I think the board will bring next time. But the investments that we've made, we are, for example, looking to see our ophthalmology waiting list reduced from around 1,300 patients to around 300 patients by the end of this by the end of this calendar year, so by December 22. For orthopedics, we're looking at a reduction from around 500 patients to around 120 patients. In general surgery, 200 patients down to 60 patients. So we are looking to see some significant reductions in our waiting list over the next 12 months. And I think we'll obviously provide that information to the board and those very clear trajectories so we can monitor our progress on that. The challenge around how we are able to restore our services is obviously linked to our workforce. And I think the one thing I would say is that across a number of our services, it is really clear that the acuity of the cases that we look after and the review of the establishments have not been done regularly. So we have identified deficits and workforce shortages in a number of areas, in addition to having vacancies in those areas. We've been particularly impacted by shortages in anaesthetics and theatre staff, which resulted in us having to really pause the elective programme for a period of time before Christmas. We have had some success in recruiting to anaesthetists, both substantive appointments and locum appointments. And over the next 2 to 3 months, there are 5 anaesthetists coming to join Manx Care as either substantive appointments or locum appointments. We absolutely need to also make sure that we are recruiting to theatre nurses and operating department practitioners, and that piece of work has started. But what I am more confident is that we have increasing capacity. We've mapped it through. So over the course of Q4, we are starting to see our workforce position improve. We have to also make sure we have sufficient beds, which is why it's really, really important. We do the work around nurse staffing establishments, onboard new nurses and open as much capacity as we can within safe staffing establishments, but also make sure we address this length of stay matter and make sure we are being able to maintain our surgical bed base for our surgical patients to be able to run the elective plan. So all those things need to be put together, but I am certainly more optimistic, and we discuss this a lot in the executive team meetings each week to make sure that what we are able to do is plan to be able to deliver a reasonably comprehensive elective programme on island, supplemented by some additional capacity from the UK, and be able to do that safely. I'm happy to take questions on that.
Thanks, Teresa. That's a very encouraging improvement since the last time we met, and a very encouraging projection for where we'll be at the end of 2022 in terms of waiting numbers. Andy?
I just want to be clear, because it's probably me losing track of it. So because there's so much going on, basically. So the work that Alan Wilson's been doing on that piece, I just wanted to, because obviously we've now got the new governance piece, which is effectively running across all services, and we know that these individual third-party players have adequate data controls and complaints management systems in place that we would approve of. I just wanted to make sure that they fully map to our governance as well at the same time, because I'm not quite sure on that at this particular moment in time. I don't know whether we know the answer.
Here and now, well, if you don't mind,
I can take that away and have a look at it for you.
Absolutely. Thank you very much.
Yeah, I think that's part of the reason why it has taken quite a while to put these arrangements in place. They are all providers who are on an agreed framework, so they meet certain standards. But they now have got formal contracts in place with Manx Care. all of the information sharing and governance agreements are in place. So we are assured they are of the right quality standard, and that is the primary reason why it's taken such a long time to mobilise these.
Yeah, it's been a long process. I just wanted to make sure for the longer term that we're going to be in these arrangements for a very long period.
Yeah.
And I just want to make sure that we have them in frame, if you like.
Yeah. I think the what we have to do is just make sure we build out gradually, and we look at all the codependencies, because actually the beds and the nursing establishment and the work the Director of Nursing has been doing, and our ability to bring in GTEC nurses is all predicated on being able to ensure we've got beds. So there's no point having the theatre capacity if we don't have the inpatient beds to put patients in. So we've got to make sure the entire pathway has a reasonable level of robustness and sustainability in order to make sure we can actually land this programme of work.
It's a great programme, by the way. I complete what Andrew says. I think it's a fantastic aim for the end of the year.
Right, anybody else? Fine, thank you. So, Anne, we move on to the workforce and culture update.
I don't really have a lot to add to what's already been said around our staffing and the priorities and the challenges we've got there. I think Paul and Teresa and Sarah all articulated that. I would like to reassure the board that workforce and culture team and the HR teams are currently reviewing their activity and what's been achieved, just to make sure that we're aligned with what Manx Care want to achieve in future. We also have a new head of learning, Paul, Emma Marshall, who we absolutely want to make sure that the Leeds offering is aligned to what Manx Care need to be delivered. And I think that piece of work's already happened with the talent acquisition team in terms of focusing their efforts and all the other pieces of work around recruitment. So I just want to reassure the board that those pieces of work were being undertaken.
Thank you. Okay, right. So, over to the finance report.
Thank you very much. So, we've received some questions ahead of time, so I think if it's all right with you, I'll begin my report by addressing those questions directly. So, the first question is, could the board please confirm the current financial budget deficit, taking account of any additional sums paid by Treasury to cover the COVID provisions? So this is information that we report every month in our management accounts in terms of what our current and forecast budget deficits are, and what our current and forecast COVID costs are. So just to highlight what's already in the management accounts is that our current year-to-date budget deficit stands at 8.7 million, 4.4 million of which is COVID costs. In terms of our full year, the second question we have is, could the board please confirm the current estimated budget deficit to the end of the current financial year? So again, this is what we report on in our management accounts every month. So as it currently stands, our current forecast deficit position to the end of the year sits at 7.1 million, with additional COVID expenditure expected of 10 million. In terms of the third question, could the board please outline the current anticipated budgetary requirement for the next financial year, and what significant improvements are currently planned which you do not already have Tynwald, Treasury and DHSC approval? So unfortunately I can't really answer that question because that's a matter for discussion between DHSC, Treasury and Manx Care. However, I can let you know that the working assumption in terms of future financial planning for the system, in accordance with Sir Jonathan Michael's report, is a working assumption of 3% year-on-year growth. So then if I just move to the management accounts specifically, there are a couple of updates. So since we last met, you'll be aware that we did a piece of work in conjunction with DHSC around the potential funding options in our back to balance plan. An options paper was submitted to Treasury, and a decision was made that the way to address our projected budget deficit was to seek a supplementary vote from Tynwald. I know that that's not quite the direction that the board had wished to pursue. However, the decision was not Manx Care's to take. In conjunction with that, Manx Care and DHSC submitted some additional business cases for funding to Treasury for costs of COVID in the amount of 10 million, to cover high-cost patients, which were a significant funding pressure for us, in the amount of 730k, and a business case to address the current pressure in terms of potential pay awards. So I'm pleased to say that the cases for both COVID and high-cost patients have been agreed. And so you'll see that the way that we're presenting our forecast has differed slightly, because the management accounts are a report of our spend against budget, and these additional costs are being funded not through budgetary but through a separate funding stream. So they've been taken out of our forecast in order to give a clearer view of what our actual performance against our budgeted baseline is. And you'll see later on in the management accounts we've shown a breakdown of what the to-date COVID costs have been, and what we anticipate them to be at the end of the year. What we've added in, however, is the pay award as the business case wasn't agreed. It was suggested by Treasury that should be incorporated into our supplementary vote request. So that's been brought in as a funding pressure now. And we've since, although I just need to clarify, we've got high-cost patients on two separate lines. Whilst we received funding for the high-cost patients we knew about, over the Christmas period we became aware of an individual patient who represented a funding pressure in year of 960,000. So that's been added in. So that's what's contributing to our 7.1 million forecast overspend position at the end of the year. So in terms of our baseline operational position, that's remained relatively stable since last month. There haven't been any major movements, thankfully. And I think it comes back to what Nigel was saying earlier, that a lot of work has been done in trying to flush out some of these pressures and some of these risks in the system. And whilst it's meant bad news coming out in the numbers, and the numbers are not going in the direction that we would like them to go in, I think it reflects a much more realistic and accurate picture. And I think it's allowed us to learn some lessons around how we might manage that more effectively going forward into next year, so that we've got more visibility on some of these risks and we account for them at the beginning of the year rather than discovering them as we go through. So I'll leave it at that unless anybody's got any specific questions.
Firstly, I'd just like to remark upon the meeting that we had yesterday with the DHSC and some of the members was really positive in terms of the numbers. So whilst they've acknowledged the fact that there's overspend and so on, what they also said was they understand the reasons why, and I think that's a testament to you and your team's work to really get under the numbers, so my compliments on that. And I'd just like you, if you wouldn't mind, just to repeat what you said in the Finance Committee about the tracking of the additional funding, because if it's coming out the baseline, we need to make sure that we're tracking how we're spending. So could you just repeat that remark that you made?
Absolutely. So what our intention is, and I'm working on finalising them at the moment, is from the December management accounts onwards. You'll see in these management accounts we've done that with the COVID costs, but Teresa's referred to a number of other business cases where specific funding, in-year funding, has been agreed by Treasury for specific initiatives such as the restoration and recovery. So what we'll do from next month's management accounts is basically summarise all of those so the board has got full visibility of the entirety of the spend that's happening across the system, rather than simply what's going against budget, because the Treasury has been extraordinarily generous in terms of supporting specific initiatives for Manx Care. It also allows us a bit of visibility to track what that spend is against those, so we've got that additional visibility and governance. So thank you, Katie.
Can I ask you the same question as I asked about the integrated performance report, namely that the accounts we have here are the November accounts, and I would be more used to receiving the December accounts at the January board. When can we hope that would happen?
It's been an ambition of mine from the beginning of the year, as you know, and I think I was probably a little bit over-optimistic. What I would say is that, for example, I'm finalising December's management accounts now, so we are very, very close. I would hope by the end of this financial year, and we would do it. I think a big part of the reason why it hasn't happened is because we've had such massive movements, such massive uncertainty. We've been reluctant to actually send out accounts that we haven't actually scrutinised to the extent that we would like. So whilst we could produce a set, they wouldn't be of the quality that we would want. But I think now, as we've gained that experience and that knowledge of what's going on, I think we can get quicker at producing our forecasts.
Okay. And my second question is that as of these accounts, and indeed as you've just said, are forecasting a year-end deficit position of 7.1 million, But if we receive the funding that we are now hoping and expecting to receive, that will bring us into a break-even, won't it?
Yes, so what will, the way the supplementary vote process works is that we will seek a sum of money that would cover our expected deficit. Usually we incorporate a little bit extra for contingency.
Right.
So the idea is that there's funding available so that by the end of the year we would get to a balanced position. We would never be granted funding to bring us into a surplus position.
No,
It's
I
simply
understand
to bring us to balance.
I just wanted to draw out the point. Officially it says it's forecasting a 7.1 million deficit, but actually we're not hoping that that will be the
No,
case.
that's what the supplementary vote is
Yeah,
for.
thank you. Any other questions for Jackie? Right. Okay, so nobody asked for any other business to be raised. We've dealt with the written questions from the public that we'd had in advance, so now any oral questions from the public? Nope. Nope. Well, in that case, we've managed to finish 40 minutes early. So,
we just want to tell Oliver this is highly unusual.
it is. This is a record. It's a record. So I'd like to thank members from the public for attending and thank everybody for contributing. We'll see about accelerating the next meeting when we find out what the position is on the availability of lunch. So, okay, thank you everybody.
Thank you.